Okay, hi, welcome everybody. We are going to get started. It's the top of the hour and we always try to start these on time. So I really want to welcome you all to the AAP COVID-19 and Children with Medical Complexity ECHO. We're very pleased you could join us today. We hope that this virtual community is the place for you to lean on for guidance and support. During each interactive ECHO session, we're going to hear from experts as well as offer opportunities to all of you to discuss challenges and experiences around COVID-19 and children with medical complexity. So this program is brought to you by the AAP in partnership with the Collaborative Improvement and Innovation Network for Children with Medical Complexity at the Center for Innovation in Social Work and Health based at Boston University School of Social Work and is funded with support from HRSA. This program does not necessarily reflect the official views of the AAP, BU, HRSA, or HHS. This session will be recorded for educational and quality improvement purposes. Slides from today's call, along with the video recording of the lecture, will be shared with you following the call. However, please note that a recording of the case discussion will not be shared, and this is to ensure confidentiality as well as to provide a safe space for your concerns and questions. Please ensure that patient privacy is protected and do not provide any PHI during today's call. Please make sure your microphone is muted during the session. You do have the ability to mute and unmute yourself to participate in the call, and we definitely want to hear from you during the Q&A and the case discussion portion of the call. If you do have any IT trouble, chat into AAP admin and we can assist you. If you have video capability, please enable it. We love to see everybody and it makes for a much more engaging session. And finally, we do have a very large group today, so we can't do individual introductions, but please do enter your name and where you're from into the chat box so that we can get to know you all. We have a wonderful interdisciplinary team of faculty for this project, and this team represents expertise in a variety of areas important to the care of children with medical complexity during the COVID-19 pandemic, including developmental and behavioral pediatrics, infectious diseases, public health, Title V, the family perspective, and more. Our faculty are helping to advise the content of this program, and we're extremely grateful for their time and support, especially during this current crisis. And we will also be inviting faculty guests for particular sessions for a wider breadth of expertise where useful. I also want to welcome all of you on the call, and we know that you all have expertise in your various fields. Many of you have firsthand experience with COVID-19. Please know that all input is welcome during the ECHO session, and we look forward to hearing from you today. Since this is our first session, I wanted to give a brief background on what Project ECHO is. So Project ECHO is a global movement of hub-and-spoke knowledge sharing networks. Each session includes a short didactic lecture, followed by a case presentation and discussion. By leveraging technology to connect our expert group with providers in the community, we're creating a knowledge sharing network that allows everyone taking part to learn from each other. And unlike webinars that may have hundreds or thousands of people on a session, ECHO sessions are purposefully kept small in order to encourage dialogue and support. This ECHO has been created with several goals in mind. Over time, we hope to increase your knowledge, comfort, and competence regarding COVID-19, its larger impact, and the care of children with medical complexity. We also want this ECHO to serve as a responsive forum for all of you to not only receive guidance, but to feel supported and heard during this unprecedented time. As you know, authentic systems level change requires that varied, seemingly disparate perspectives are considered in mutual partnership. We've limited this cohort specifically to the CoIIN teams so that you may take full advantage of your interprofessional peer networks to address the emerging and longer-term needs of families in the wake of COVID-19. So today's session is going to start with a short overview on what we currently know about COVID-19 and children with medical complexity. Following the lecture, we'll have time for some Q&A, and then we're going to move into our case discussion. So with that, I'd like to present or introduce our co-presenters today. So Dr. Dennis Koh is a general pediatrician on the faculty at the University of Buffalo and an attending physician at Oshai Children's Hospital. His research and clinical practice focus on children with disabilities and medical complexity. And he also serves as the chair of the AAP Council on Children with Disabilities. And Dr. Megan Fisher is a pediatric infectious disease subspecialist who practices in New Jersey. She's previously served on the AAP Committee on Infectious Diseases and wrote the chapter on infection control and prophylaxis in the Red Book. She currently serves on the AAP Board of Directors and has been active in several other AAP ECHOs. We're so thankful that both of them are presenting this talk today. With that, I'd like to have them each briefly disclose to us if they have any conflict of interest disclosure.
This is Meg Fisher. I have no disclosures.
Hi, it's Dennis Quo. My wife is a graphic designer that does some freelance work for a company that does artificial joint replacements. Otherwise, I have no other disclosure. That disclosure has been documented to AAP previously.
Great, thank you so much. So with that, I'm going to turn it over to Meg to start.
Okay, so I always start with a disclaimer, and that disclaimer is that much of the information you hear today will be out of date within the next few hours to days. So this is an evolving pandemic, and it's great to have sessions like this to keep us all current with what's going on. Next one, Shannon. So as you know, this is a pandemic that has literally affected just about every country in the world. And I had to get out a global map to figure out what the white country here is next to Iran, and it's Turkmenistan. And I have a feeling that it's not that they have no disease, but somehow they just haven't reported it. The other thing you get a feel for from this map, this is from the World Health Organization, and it shows you where the disease is most common at this minute. So not overall, but at this minute, and you can see the hotspot is the United States. If we go to the next slide, we can see within the United States, things are not equal. So there's a lot more disease in the Northeast, but there also is plenty of disease in Illinois, in Florida, in Texas, and in California. And this map is available on the CDC website. It's updated literally every day, and it is an interactive map. So all you have to do is hover over the state, and you can find out the exact number of cases and deaths in each of the states. And as you can see, if we look overall in the US, we're up to over 1.5 million cases and over 90,000 deaths. Next one. So this is a very rapidly evolving pandemic. We know from the early reports from China that most illness is mild. In their large series, 81% of cases were mild, 14% severe, and 5% critical, ending up in a critical care unit. Now, these numbers have actually been confirmed in other settings, and it is not only are 80% mild, but in fact, we now know that there are a significant number of people who never develop symptoms at all. They are shedding the virus, but they never develop any symptoms. We know that the illness is clearly more severe in adults and more severe as you get older. The major symptoms are fever, cough, sore throat, shortness of breath, malaise, now loss of taste and smell, and a variety of other non-specific symptoms. The illness is more severe at all ages if you have underlying chronic disease, and it is just more severe in even healthy elderly people. So the fatality rates vary dramatically. In China, the overall fatality rate was reported to be 2.3, but as you look at the age distribution, it was no deaths under age 10, about 8% as you get to be over 70, and up to 15% over 85. And again, that has been confirmed in the United States, where we have seen similar, if not higher, fatality rates among the oldest people. As far as the overall fatality rate, we think it's almost certainly high. The reports are higher than the actual rates because we're only identifying people primarily who are symptomatic. So that denominator makes a big difference. As we realize that more and more people are asymptomatic, the actual case fatality rates will go down. Next slide. As far as transmissibility, the incubation period is between 2 and 14 days, but most people get within 4 to 5 days from exposure. We also know that by 11 days, about 90% of people who are going to develop symptoms will develop them. There's a new concept that people are talking about. It's actually not new, but maybe new that we talk about it. And that's this thing called the basic reproductive number. And it gives us an idea of how transmissible an agent is. So how many second cases are there on average for each person who's infected? So if we look at this for SARS-CoV-2, which is the virus that causes COVID-19, we know that it's more transmissible than SARS-CoV-1. And if we go to the next slide, this puts it into perspective with a whole bunch of different viruses. So the star is SARS-CoV-2. You can see that the most contagious of the viruses that we know of is measles, and then smallpox and polio. But then the first SARS agent was a little less transmissible than the current agent, and both of those a little less than Zika, but around the same as HIV. So this gives you a feel for how likely things are to be transmitted. And of course, that means how likely the rest of the population is to be infected. Next slide, please. If we think about pediatric cases, there are far, far fewer pediatric cases compared to adult cases, and very few pediatric deaths. So pediatric cases have accounted for somewhere well less than 5% of cases. And in both China and Italy, it was only 1.2 to 1.5% of hospitalized cases. Now, it's not clear whether this is because truly there are not children being infected, or more likely because children have such mild disease, they are not being counted and less likely to be tested. The clinical presentation in children has ranged from totally asymptomatic to mild illness that looks like any other upper respiratory tract infection, to pneumonia, to respiratory failure, and now we have this newest described entity of multi-system inflammatory syndrome in children. This appears to be a post-infectious condition related to the inflammatory response rather than related to the virus destroying cells. So this is the immune response that has gotten children into trouble. We do know that both asymptomatic and symptomatic children have been found to shed virus. As to how much they shed in comparison with adults, there are conflicting studies. Early studies showed they shed lower amounts of virus, but current studies have not borne that out. So we know that they certainly can be contagious, but they do not appear to be the major transmitters. And in most cases, the children are getting disease from their parents or older family members rather than being the ones that are transmitting the virus around. Next slide, please. This compares the signs and the symptoms of illness in children versus adults. And as you can see, for just about everything listed there, the symptoms are less in children than in adults. The only exception is runny nose. But children are much less likely to have fever, cough, shortness of breath, myalgia, sore throat, headache, nausea, abdominal pain, and diarrhea. And you can see it varies depending on which symptom you look at. Next slide, please. So having described the disease, how do we make the diagnosis? And really the way to confirm this diagnosis is by doing the polymerase chain reaction testing on body secretions. Right now, the major test that's being done is on nasopharyngeal. You could also do the test on oral secretions, on bronchoscopy secretions, and currently there is one test approved for use in saliva. So all of these tests have different sensitivity and specificity, and we're still learning how to use these diagnostic tests. As far as who gets tested, that's generally coordinated by the local and the state health, public health departments. And these tests are now commercially available, but their turnaround time varies dramatically. So some tests can be done in as short as 30 minutes, where others take 8 hours. And how fast you get the test result depends on how fast the test is to run and how quickly the test is being run. So if you have to send the test out to a laboratory for it to be done, it's obviously going to take you much longer to get the results. So you can get results in anywhere from 10 minutes to several days. Next slide, please. So who should be tested? And there's been a lot of prioritizing of the testing, mainly because we've had limited number of tests. As the test kits become more available, there is a bigger push to test lower priority people, But for now, the highest priority people are hospitalized patients with symptoms, healthcare workers, first responders, those working in workers who are in congregate living settings, and residents in long-term care facilities, because we know that these have been areas where when one patient is infected, there's rapid spread through the living setting. The next priority are persons with symptoms of potential coronavirus infection. And as we noted, this includes fever, cough, shortness of breath, chills, muscle pain, new loss of taste or smell, vomiting or diarrhea, and or sore throat. And then the lowest priority are people who don't have symptoms, but the health department or clinicians have determined there is a particular reason why you have the need to know if they are infected. And again, as tests become more available and as we begin to open up our local areas, testing is definitely going to be done more in the lower priority groups and in asymptomatic patients. Next slide, please. So what about treatment? Unfortunately, treatment remains mainly supportive. I mean, support's always good, so that's not unfortunate. But we don't have a lot of specific therapy, and support seems to be the major treatment. Remember that mild cases will not require hospitalization, and the vast, vast, vast majority of children with disease have mild illness and will not require hospitalization. Of course, there are always exceptions, and those exceptions prove that rule. Now, we do want all cases to be isolated. The problem is we don't know for sure how long a person remains contagious, so it's difficult to know exactly when we can safely bring people out of isolation. And the Centers for Disease Control has put out 2 testing strategies for when you can come off of isolation. One involves symptoms, so you have to be afebrile for 72 hours, significantly decrease in your symptoms, and at least 10 days from when your symptoms started, or a testing method where you stay isolated until 2 PCR tests at least 24 hours apart are negative. There are several drug trials in progress, mostly in adults. Remdesivir has gotten the most publicity, and as you know, it is now available as under a EUA, so Emergency Use Authorization, and there has been compassionate access for pediatrics, and now under the EUA, children can be treated as well as adults. There are a variety of other antivirals being tested, and the other thing that's being tested is convalescent plasma. So we don't know how all of these will pan out, and we don't know the ideal treatment for children, and the reason that is because mainly children are not requiring specific therapy. So that's sort of a good thing. Next slide. And I believe with this, I turn it over to Dennis. Thank you.
Hey everybody, it's Dennis Quo. I'm going to go over a little bit more about COVID and children with medical complexity. Next slide, please. So with medical complexity, we define them as children with multiple significant chronic health problems that will affect multiple organ systems. And the framework is that a child with medical complexity will have functional limitations, high healthcare need or utilization, and often the need for medical technology. Another term that's frequently used is the children who are medically fragile, and a number of them will have underlying lung disease. They may have neurodevelopmental delays or disabilities. They may have a tracheostomy. Many have impaired communication, so they may have considerations for communication, and there's frequent healthcare system interactions, and may have total care needs for activities of daily living. Next slide. Taking a step back, as Meg said about the pediatric experience, so I get a lot of questions about how are the children with medical complexity being affected with COVID. The reality is that children generally are not really getting all that sick from COVID. The hospitalization rate at this time seems to be about 0.2 to 0.3 per 100,000. There is some predilection for the youngest infants being at risk for hospitalization, And then there's some, as you get older, like the 15-year-olds, the 17 to 18-year-olds, you start to see more that will become more symptomatic. There are, of course, some race and ethnicity disparities for COVID overall, and we're seeing some of the same in children who are hospitalized. And as Meg also mentioned, there is a multi-inflammatory system that is currently being characterized. We have seen a handful up in Western New York. Most of the reports right now are coming out of the New York City area, and I expect we'll start to hear more and more of that as we see more and more cases in children. Next slide. Now, regarding medical complexity, the reality is that there's not a whole lot of data. In the CDC report, which Meg referred to earlier, about 23% of children who were originally reported in there to have COVID, that 23% had an underlying condition. That includes, in particular, pulmonary, like asthma, cardiovascular, or some immunosuppression. And there's another report that recently came out in JAMA Pediatrics, which looked at ICU admissions, keeping in mind that hospitalizations, I mentioned, are actually pretty rare for children generally. And the vast majority of children who are being hospitalized don't make it into the ICU. Most of them just stay on the floor and go home. For those that actually do make it to the ICU, we are finding that most 83% in this particular report had pre-existing conditions. 40% they defined as medical complexity also had that level of complexity. And the vast majority of patients in there needed some level of respiratory support, and that's why they were in intensive care unit. The experience we've had in Western New York, we are a metropolitan area of about 1.3 million. We have an antibody positive community rate of about 8%, and we've had 8 children hospitalized so far, and none of them went to the intensive care unit. So that gives you some idea, just one center's experience. So as a general rule, we are seeing some, but not a whole lot of kids coming into the hospital with COVID. Next slide. So the care considerations really are more likely to include care network disruption. So by definition, a child with medical complexity relies on a fairly intricate network of providers, support, therapies, medications to be able to reach for their maximum potential. So you have to think about the access to primary and specialty care. That will include whether they can physically see their physicians, or whether they would do telemedicine, or whether they go through telephone care. Supplies and medications with the supply chain with disruptions can be issues. Schools having closed to in-person instruction and maintenance of therapies, the economic health of the family and the community, and also the caregiver health. In particular, you have to consider parents, grandparents, visiting nurses, therapists, and levels of extended support. And because adults are more likely to get sick, we have to consider whether that will disrupt the care network for the child. Next slide. So as clinics have closed their doors to in-person visits or severely restricted the number of individuals who come through, this thing called telehealth has come around, which is really the use of electronic information and communication. Telehealth we're using as a pretty wide a definition of telephone to televideos to use of the patient portals. And all of them are generally being covered in some way, shape, or form by most payers. It does depend on the region. That's something that you would want to figure out with your own payer network. But in general, many payers are covering telehealth appointments. And many practices are offering telehealth now. If they hadn't been offering before, there are a variety of third-party software applications that are being used. You may have heard names like Zoom, Doxy, WebEx. Those are out there. Those are increasingly being used. Even non-secure modalities like FaceTime are okay to use per CMS for during the public health emergencies. We're also finding that schools and therapists are increasingly offering the same modalities. Locally here, we're starting to see more and more of it come around. You have the following things to consider. The first is that the technology does differ because many providers scrambled in the last few weeks to figure out how to implement them. Some will use phones, some will use computers, the laptops, some will use Wi-Fi, some would use data plans, and you have to be sensitive that the access to say broadband with a laptop and a Wi-Fi is not necessarily equal. Another consideration is that language services and how well they're integrated. If you have a family that is limited English proficient, that is something that you have to consider. And the third is just the acceptance on both sides. We have providers that may be resistant to using telehealth. We have families that are resistant to using telehealth. And there is also a lot of preparation that has to be done on both sides in order to make sure that you get the most out of the telehealth option. Next slide. In the areas of supplies, medications, and therapies, many payers have become much more accommodating to be able to account for the fact that families are pretty much staying at home as much as they can. Medicaid HMOs and state Medicaid, for example, may have early fill options or 90-day override on maintenance prescriptions, although that's not something that's generally available for controlled substances. Many pharmacies will have considerations for probably delivery services or drive-through. That's something you can consider. We are hearing of examples here and there of supply network issues, medication shortages that kind of go in and out, and maybe not necessarily nationwide shortages, but the supply chains get disrupted as individuals start to have, can they over ordering or trying to stockpile medication. So we've certainly seen families that have been out of medication for periods of time. And keep in mind that sometimes when you have to switch around medications, you may have to go with pre-authorizations. And so basically the more planning you can do in order to address supplies, medications, and therapies, the better off the situation will be. Next slide. So social determinants, those that work with me know just how important it is that we talk about the social determinants being the majority of what really determines the health of a child and family. One thing to keep in mind as we go through social determinants is that the prevalence of coronavirus in the community does impact the ability for the community to respond. And there may be local hotspots in your community or in your state, and there may be local hotspots even within your community, such as assisted living facilities. So that's something you have to keep in mind as you look at the social determinants. Or there may be a very low prevalence of coronavirus throughout your entire community, but your economic fallout of having to contain the virus spread is fairly significant. And so with economic insecurity, we and our partners in the community are just hearing a lot of food insecurity. We're having issues with of children getting the right formula. That seems to be a little bit better locally of late, but that is things that we have heard. Diapers can be in short supply. Other supplies can, we've heard about, again, supply network issues. Now, regarding the schools, many of our children receive therapies through schools or counseling in schools. The IFSP for early intervention or the IAPs for kids 3 and over. They are really to be maintained, but the ability for the schools to maintain them has been variable. And also the ability for example, we have children that required a certain level of therapies and consistency in school, and if they don't get them, it also impacts their medical care, and there are adjustments that we've had to make. So just consider just what the impact of social determinants as well as the interaction with the child and other areas of their care may have. Next slide. When we talk about consideration for caregivers, when we're talking with parents and families, first we ask, well, what can be handled through telemedicine? We really want to try to keep as many kids safe as possible, although we don't see a whole lot of kids getting really seriously ill from the coronavirus. We don't want kids getting it in general. We don't want the adults getting it, and it does impact the caregiver. So what happens if the caregiver gets sick? Do you have a backup plan because the caregiver may be at high risk for the illness? Think also about with caregiving, what is the risk incurred by having home health nurses and therapists and visiting nurses come into the house? For example, if you need weights in a child, can you maintain the safety of a child by having a visiting nurse versus coming to the office in a prepared environment, or finding if we can get a scale for the family. And finally, for this slide, consider the mental health implications. Whether the impact. Some children are actually doing okay because they are thriving in an isolated environment, and a lot of children are not doing nearly as okay. So those are things that we have to consider, and sometimes we have to just ask outright. Next slide. So in conclusion, children with medical complexity may be at risk for severe illness, but overall severe illness we're finding is actually pretty rare. Now that's medical illness, like things that would land a child into the hospital. And so the things that we're really seeing much more frequently is the disruption of the care network. We have really seen a massive disruption economically and socially of the care networks that really support our children and families. And even as the states start to reopen in controlled fashions, we expect that this is just going to go on for months, if not the next several years. So we want families and providers to address the following. Plan for the possibility that the child and a caregiver becomes ill. What happens to your care network? Who's going to take care of things? Who steps in for support and such? Number two is consider how we maintain the healthcare access to therapies and access to supplies, including telehealth. We have in our primary care clinics in Buffalo a 60 to 70% reduction in in-person volume. To me, that does not mean that all of a sudden that we got rid of 60 to 70% of morbidity in the community. We still need to take care of it. The third is to keep in mind the education plan does not stop, but make sure that it is proactively addressed and coordinated with providers. The fourth is to reach out to your community-based resources. They are there. They are seeing volume. They are seeing need. Several well-placed phone calls to talk about referral networks may be hugely helpful to your care. Finally, this is pretty unprecedented unless you remember the Spanish flu back in 1918, and I doubt many of us do. Be flexible, be creative, and be forgiving. We're all trying our best. We're all learning from each other. And it's opportunities like this ECHO and the CoIIN which allows us to be able to implement best practices. Thank you.
Great. Thank you so much, Dr. Kuo and Dr. Fisher. As you can see, we have some resources here, which we'll also send out to you as a follow-up along with these slides. But I'm going to pull down the slides for a second and just see what questions the group might have. We have a few minutes for to maybe take a couple questions. So if anyone does have a question, you could go ahead and unmute and ask your question, or you could put it into the chat and we'll call on you. I know it takes a minute sometimes to unmute and ask your questions. If you do have a question, let us know. But as I think was mentioned in the chat, know that a lot of these subjects that Dr. Kuo just talked about are going to we're going to take a deeper dive on them in some of the future ECHO sessions. So just know that that's coming, and so we'll have an opportunity to discuss those a little bit more in depth. So last call for any Q&A before we move on. Pat, it looked like you unmuted. You might have a question.
I do. Can you hear me?
Yep, go ahead.
This is for Dr. Kuo. The data that you presented from the CDC, I'm sure that was pretty up to date. I've seen and participated in numerous webinars recently, and there is some areas, especially in New York, that the children have been more significantly affected. And when they looked at some of the numbers that they presented, it looked like the children did have a greater percentage of underlying issues, abnormalities, whatever we want to call, what they had, with some children being compromised from some sort of immunological issue. So the CDC data then is drawing from everyone, so that's why the numbers appear lower. Are you seeing some hot spots that are maybe our children are more affected?
So I'm in New York State, but the part of New York State that I'm in we would characterize it as, Governor Cuomo calls us a moderate hotspot. We were at 8% antibody prevalence. Other parts of the state are at 2%. New York City is closer to 20, maybe a little bit above 20%. We're really not seeing a whole lot here. And I know that my New York City colleagues have definitely seen more, particularly for children who are living in some assisted living settings as well. There has been some manifestations there. I do think that when you have, New York City has a prevalence that's 2 to 3 times what we have here. The more kids we see, we are going to see them. And it does make sense that, RSV flu will affect children with medical complexity more significantly. And by those odds, I think we will see those with children with COVID. We're just not seeing it in large numbers relative to what's actually out there. And, my colleagues in New York City have said that they did see some severe illness, but the pediatric units weren't overwhelmed. If anything, they were taking on adult patients. Meg, I'm interested in your comments since you're closer to New York City than I am.
Yeah, I'm right across the river, so to speak, in New Jersey. And actually, my pediatric floor was closed so that we could become an adult ICU. And many of the pediatric units in New York City were closed so that they could take over adult care. So I think, while you may hear, okay, there are 100 children with this multi-system inflammatory syndrome. That sounds like a lot, except when you put it into context of 1.5 million adults. So, children are still not very much affected by the virus. They are very much affected by this epidemic, by this pandemic. And we know that all the things that Dennis talked about are going to be hugely significant for children, particularly those with special needs.
Could I follow up a quick question with Meg? I think we're all surprised that COVID-19 has not affected the pulmonary system of our children who are at pulmonary risk. Clearly has with adults. Any speculation as to what's going on here? I mean, it just is, it decides it's not going to hit the pulmonary system.
The obvious question, and it would get me a Nobel Prize if I knew, people talk about whether or not it has to do with receptors. I think we don't really have a clue at the moment.
Do you think,
or at least I don't.
Meg, this is Pat again. Do you think that our ability to physically distance and to offer, an extra layer of care to our children offers some semblance of we're just keeping them away from the virus?
Sure. I think physically distancing has been great. I'm never a fan of school closures, but I think in this particular instance, it probably was the right thing to do. As soon as we can get them back open again, I think that will be good for our children in general. But I think, if you look at the experience in Italy and the experience in China, it's the same. There were, hundreds of thousands of adults, and there clearly are children infected. They just don't seem to be particularly ill, which is fabulous and great news for children.
Okay, thank you.
Very good. So let's take one more question. And I saw there were a couple questions, similar questions in the chat about schools. Lisa, I wondered if you could unmute and ask your question, which I think also gets at Tamara's question as well. Are you there, Lisa? There, go ahead now.
Okay, thanks. I guess my question is, and this is where we're in a paradox, I think, and so it's helpful for me to think about this as a paradox. We have kids who are clearly, as you pointed out, with the limited services, families are really starting to buckle, and as we go for this in a longer haul, what can be done, or in prudence, what we have to kind of balance the needs of some of the the lack of service and the lack of support. And also, has anyone done any creative thinking around plans for families if the adult does become sick, and are there plans in place in states, other states, for where those kids might go if there aren't backup folks as well? So anyway, I'm just kind of, my question is more about what can we do to minimize risk as much as we can, but provide the support that folks need. And I think schools and the school support piece is a big part of it.
Dennis, you're muted.
Yeah, I am muted now, huh?
Now you aren't.
Okay, am I off now? Okay. There were a couple of additional questions about, and I've seen in the chat that are along those lines about the coordination with schools. I think this is an area where we need to be really focusing on. That's a personal opinion, but that's also just discussing with a lot of folks, through discussions. And I know I've had discussions with some folks on this call about that area. I can tell you that discussion with schools here has been evolving because, everyone went from shut everything down quickly in person to in the last few weeks, I've started to notice the therapies have started to get better because I think folks started to manage to reach out to their families as well. Every I think school district in every state is a little bit different. For example, I've had to work with the state and the governors to get a couple of our schools who serve children with disabilities actually closed. And that's actually not something that I think would apply with every school district. But I think those partnerships, like reaching out to, and here would be like the Buffalo Public Schools, or figuring out, the county association schools and say, we have a lot of children out there that really depend on these therapists. What can we do to support? And so we have called school principals and told them, we have this feedback, what's going on. Sometimes we found missing phone numbers. Sometimes we find that it has to do with when the families and the schools are trying to reach out to each other. We've managed to make connections between some families and the principals, and the therapists have been trying to get in touch with each other. There's, I think, just the basic reach out to the schools is one level. Working and understanding your schools, the landscape of how schools districts are making decisions at your county and state level is another. And I would encourage folks to really just delve into it. I don't think there's a playbook, except just got to try it.
I do agree with the one comment by Kara on the chat box. Families with of children with complex medical needs are incredibly aware of infection control in general. And I think they are very nimble and able to manage much better than some of the rest of us who sometimes just throw up our hands. So a really good point. Go ahead. No, go ahead.
This is Kara. I just wanted to piggyback off of, thank you, Meg, for bringing that comment to light, and just kind of tie it into what Dennis was saying too, that, we're hearing from family voices from families, a lot of frustration with distance learning, as everybody can relate to, right? But for those with IEPs and IFSPs, it's even more so. And so any efforts to do that kind of contact and network with the school systems really should be linking up with families and family-led organizations. There's the parent training information centers in every state, and they're on the cusp of what's going on in creative ways as well to try to get IEPs in place. But, also quite frankly now too, sometimes adding more therapies even though we know that that's what kids need, it's so stressful and chaotic at home that you have to be cautious and partner to make those decisions of how you do that together. So just encouraging going with the families and partnering with families and family-leds on all that.
Very good. So I want to pause the Q&A for a second so that we can move into our case discussion. We don't have a ton of time left, but since this is our first ECHO, and I know many of you are new to ECHO, we wanted to talk a little bit about how the cases are going to work for the sessions. And then we'll do kind of a mini case presentation and discussion today, so you can kind of get your feet wet and see what it's like, and learn a little bit more about what we're going to be doing going forward. So I'm going to pull up our slides again. And just know that we will be following up with you today. We're going to send you a case form, and that's to kind of help guide the case presentation process. We're going to be seeking patient cases from you all, and it doesn't have to just be a patient case. It could also be more of a process or a policy-based question. But we really want these cases to come from you all during the sessions, because the point of the ECHO is to really take this opportunity to learn from each other and learn through these cases and support each other as well. So for today, Dr. Kuo is going to present the case for us. This is going to be an example case, so he'll present it. And then Dr. Fisher is going to guide us through discussion. We'll use the rest of the hour to really kind of work through the case together, ask questions, and discuss. So Dr. Kuo, I'll turn it to you.
Okay. Hi, everybody again. This is actually one of my patients I've been taking care of for the last couple of years. So she's a teenager. And the background is that I mentioned earlier that we are a moderate hotspot, so we know there was a fair amount of community circulation. Our hospitals did not reach the overrun surge level, although there was a lot of planning in there. And we definitely saw the disease hit certain communities in our area. So with that said, this particular patient, her diagnoses are autism with severe, sorry about the typo, intellectual disability. She has a feeding tube, so she takes a little by mouth. She has autism. She has asthma. She has overflow incontinence. She has a number of musculoskeletal diagnoses as well. She lives with her parent, her mother, and they live in housing that was created, that's there specifically for individuals with disabilities. And so her mother just contacted me. It was actually through email communication, and in giving me her usual update, because we try to touch base monthly regardless of what's going on. She just happened to casually mention that both of them were sick, and they've been sick for a couple of weeks at that point. So there was actually a fair amount to unpack here. This family has fairly limited means. They rely on a fair amount of social support that we spent a lot of time setting up, because they also, one more bit of information is that they also recently moved to the Western New York area from a different part of the state. So we spent a lot of time setting up a lot of these resources. So in summary, they're at home. We know that COVID was circulating in the community, and they're sick. So I'm going to stop there and give it over to Meg, because I'm sure that there's going to be a lot of questions and things to walk through.
So what we like to do after the case presentation is open it up to the whole group to see if there are any clarifying questions or other things that you would like to know from Dennis. And then we sort of will answer the question of what's the next step. So does anyone have any specific questions about the family that they would want to ask?
Yes, can I ask a question?
Yes, please do.
So what support systems does this family have?
The family does not have any other family in the area. They are set up through support systems that are available to us in New York State. The child has a case manager that through the Office for Persons with Developmental Disabilities. The child is currently being homeschooled and gets a variety of therapists that were formerly coming to the house. We cannot put the child in physical school because of her care needs. However, her case manager passed away the previous week, and it was rumored that she had COVID also.
Good. Tamara, I saw your hand up. Did you have a question?
Tamara,
that was exactly my question as well. What support systems did the family have, including peer support
And, go ahead, Kate.
Thank you. I had two questions. One is, how overwhelmed does the mother sound when you talk to her? And the second is, do you have a sense of what they're doing for food? How they're doing with that?
Yeah, that's a really good question. She was pretty overwhelmed, and in retrospect, she was sick. So she was exhausted. She was sick. She actually was a little bit better, but she had said, she had just started to get over the phase where she could physically get up and walk over to the bathroom without getting winded. We asked about food. We asked about medications. We asked about supplies, and they were running short. They did have a new case manager that was she hadn't called yet, but we screened for all of it, and they were running out of everything.
Dennis, this is Marie Mann. Just a question. When you say both the mother and the child are sick,
Mm-hmm.
I think one of the first things is what's the level of sickness, what defining sick.
Yeah.
And because that will help you triage as to, how severe the, to her condition, whether they need to be immediately seen, in the hospital.
Yeah, so when I heard this message, I called my nurse care coordinator, said, I want to telemedicine with them like today. And we got them in. And so when I was able to liaison on them, they looked okay, meaning that they were both sitting up and they were talking. And I noticed that both of them were able to converse without getting short of breath. But in going through the symptoms, I mean, both of them had cough, both of them had night fevers, both of them had sweats. The daughter was basically coughing more and congested more than anything else. And it was the feeds were okay, had the night sweats, but did okay. The mother had about a week where she almost couldn't get out of bed. And it does make me think, because the previous time I'd spoken with her was a month earlier. So we were just doing a monthly check-in. So, so my immediate concern was, is the mother well enough to take care of her daughter? And when I saw that she was actually sitting up and able to talk, I felt better.
I think James Perrin raises a good question. If the mother needs to be hospitalized, now what happens to this child? So, yeah.
And without the informal supports, I actually called my hospital medicine director colleague and said, are we prepared to put the child in the hospital for a few days? Because we didn't have any of that additional support. They had decided to move to Western New York without, they had no family in the area. So that is something that we had to work through. Not ideal, but if we had to do it, we had to do it.
And I'm sure this is a situation where the mother's not going to tell you how sick she is because she doesn't want to be hospitalized.
Not until I ask specific questions. And that's the thing. I definitely had to ask a very specific question before I got that history out of the mother.
Okay.
Yeah, keep in mind that she emailed me because she wanted to do a monthly check-in.
So I think lots of points have been brought up here. What are the people in the group seeing in terms of family supports? Do you have people delivering food in your areas? Do you have where do you turn if you need to find support or help for your parents? And that's going to vary by community. Give us an idea of what's happening in some of your communities.
Meg?
Go ahead.
Just want to mention, I've been in contact with a number of programs that are supported by community health workers, particularly in New York City, in Philadelphia. I was just on a call with one of our ACOs here in Massachusetts who are deploying community health workers. And this is a group of people who are fearless, among other things, and can and are getting food to people, working on things like housing and so forth. So I'd love to know from others how many people are deploying community health workers, but particularly in this situation, they are heroes. They are really doing incredible things in this crisis.
That's an incredibly good thing to remember. And a lot of us sort of have the idea that everybody's stuck at home and nobody's doing anything, yet visiting nursing associations and lots and lots and lots of community people are doing things. They are delivering food, they're delivering meals. Some of the schools have figured out ways that they can deliver meals to people. But of course, the problem is particularly if you're isolated at home, you may not be aware of these services. So how do you figure out those services in your area? What ways do people, what do you take? I mean, do you Google it? I mean, where do you find out what's happening in your particular area? Any thoughts?
211 services around the country are my first thought.
Say it again.
211.
211.
211s.
Excellent. And Kate, you had a thought?
I was going to say the same thing. Plus, we have a maternal and child health hotline here that I know some states have a version of their own too. Like here it's within reach, but other people may have other ones.
This is Jim, just to support Judy's insightful comment about community health workers. You know, in care of kids with chronic illness and disability, but now I think more broadly as we're experiencing this pandemic, the real need for moving far more into team-based care and away from clinicians trying to sort of manage the cases themselves is so overwhelming. And I do hope that one of the longer term impacts of what we're learning together will be the substantial expansion of teams, because there are team members who are vastly better than clinicians are in general in finding resources health families need. I must say, one of the things we're experiencing more often than we'd like is the issue of housing. So we had a family, for example, where the grandparents both died of the virus, the parents were both infected, and one preschool and 2 elementary school kids had no place to go, no family around them. I know friends of mine at Boston Medical Center are seeing some similar circumstances where just finding housing for young people has been extraordinarily difficult. And no one's got really good answers to that yet. We're doing some strategies to sort of make do, but that's all they really are.
Yep. Hopefully, unfortunately, as this pandemic continues, we're going to have to keep looking for those ways to help out. I would say in my area, you know, our residents haven't been able to take care of patients because we don't have pediatric patients. But what they've done is outreach. We have a family success center in New Jersey, and the residents are now gathering food and stuff to take, diapers, cleaning goods, all of those things to take to these family success centers to try to help these people who are most at risk. We have a large immigrant population, so there's another situation where we're trying to really reach out to these families where they live. I see that we're just about out of time, so I'm going to shift it back to Shannon to kind of finish up.
Yeah, thank you so much. I want to close just first by thanking everyone for being with us today. This was a really great first session. We're so thankful that we have you all and that we're able to meet this way. This group's going to continue to meet regularly on the 1st and 3rd Wednesdays, same time, same place. So this is a specific cohort for the CoIIN groups. Like we said, we want to bring you together. We'll continue to do a deeper dive into these subjects that deal with children with medical complexity and COVID-19. And we'll be able to work through some cases together. So following the session today, look for an email from us. We will follow up with you. You'll get the slides from today, a video recording of the lecture. We'll also send you some more programmatic information in the case form. So we hope you got a little mini taste of the case discussion today. Next time, we really want to get a case from one of you that we can dive deeper into and really discuss all the challenges and give you some feedback. So again, look for that follow-up from today. We'll also be creating a listserv for this group, and we hope that that'll be a way that we can kind of continue the conversations going in between echo sessions and work through challenges and also be another line of support for you all. So with that said, I know we're out of time. I don't want to keep you. Thank you, everyone. We appreciate you all, and we hope to see you next time. Take care, everyone.